Welcome to the show. I'm Dr. Ronald Yap. Today, we will be talking about bladder cancer with Dr. Bill Santis. According to the American Cancer Society, an estimated 79,000 people will be diagnosed with bladder cancer this year, causing 16,870 deaths. It's a men's health issue because men are 4 times more likely to develop bladder cancer over women, and it is the 4th most common cancer in men. About 50% of cancers are superficial or in the initial first lining of the bladder. And unfortunately, 1 in 3 are deeper into the muscle layer of the bladder. It's a lifelong disease requiring continued follow-up due to its nature as a recurrent disease. Some background on Dr. Santis. So thanks for joining me today.
Thanks, Ron.
He received his undergraduate degree in biology at Tufts University, master's degree and medical degree from Boston University School of Medicine. Dr. Santis completed urology training at the Brigham and Women's Hospital in Boston. He specialized in urologic oncology and is the director of the prostate and urologic cancer program at Concord Hospital. He's an all-around awesome guy, so thanks for coming, and welcome.
Thanks for having me, Ron.
Yeah.
It's great that you're doing this.
Oh, thanks, man. It's fun.
Yeah.
It's fun. I'll tell you, we just talked about it before we started taping. We worked the whole day, get washed up, put some good clothes on, and we're here taping.
You got washed up? This is what you look like washed up?
Yeah, well, I shaved a little bit, so. Yeah. So I remember you welcoming me when I started. That's my 11th year here. So how many years have you been at Concord Hospital?
This summer it'll be 17 years. I finished my training at Harvard in 2000 and packed up a dog and 2 children and my wife, and we headed north and came here and had our 3rd child and several more dogs, and I've had a wonderful career here.
Yeah.
It's been a great community to raise the family and a burgeoning medical center.
Yeah, yeah, and you are number 4, right? 4th person.
Right. Dennis Card retired, and I took his spot, so there were 4 of us here. And slowly over the years, we've been able to recruit good people and provide more and more subspecialty care. And this summer, we have our 10th physician coming in, and it'll be 17 providers.
Yeah, I count them up. Yeah, we have 10 doctors, we have advanced providers, we've got PAs. It's amazing. I think in total we've evolved to be one of the largest practices in America. Not super huge, but we're definitely up there.
I think for subspecialties, that's kind of the way things are going. That you have more complex work being done at regional centers, and less lone wolves out there. Yeah. Able to do a little bit of everything.
Yeah, I mean, nothing against the groups that are doing all of it, but in our practice, we have men's health program, stone program, cancer, pelvic medicine, and the people that are focused on those. Yeah, reconstruction coming up. We've got another partner coming. He'll be on the show soon, and we're just whatever you're doing the most of with the highest complexity and have the most reps in. Those are the people that you don't have to be a doctor to know you're logically going to have more facility with those procedures and better outcomes. So not only are you, a good guy, brought your family here, only job out of training, fighting cancer, you also have cancer in your pedigree, because if we dig back in the Dr. Santis trivia file, you're also the descendant of Dr. Sidney Farber, the basically pioneering doctor, basically created chemotherapy, the concept of chemotherapy. How has it felt like to have that? Do you have a weight from the pedigree of
not at all
cancer fighter, man?
Sidney Farber was my mom's dad, and I was pretty young when he died. And his story is a very interesting one because he was a pathologist, the head of pathology at Children's Hospital, and he saw these children with cancer kind of hidden in a ward in an isolated part of the hospital, and was frustrated and wanted to try different kinds of technologies, different kinds of medications, different kinds of poisons to help try to cure these kids. So think about a pathologist coming out of the lab and trying to do clinical medicine, but he was able to do that and get some of the first remissions in childhood malignancy and leukemia, and then develop research, help go to Washington and establish NIH, and ended up contributing quite a bit. If you have not read The Emperor of All Maladies, it's a book that won the Pulitzer. It's worth reading, or there's a PBS special by the same name. So yeah, he was an interesting guy, and he did a lot of great work, but that never really weighed upon me. I I'm a people person.
Yeah.
I enjoy taking care of patients. The older I get, the more I appreciate that it's a privilege to take care of patients, and spending your life helping others, what's better than that?
Yeah.
And then I enjoy science, I enjoy technology, I enjoy how things change, I enjoy the team nature of cancer care, and I love to operate. You know, fundamentally, I'm a surgeon.
Yeah,
I like to fix things.
You call it the eye of the tiger, baby.
Yeah, no, I like to operate.
That's cool. You have to have that edge too, you know, to be able to tackle these things, you know.
Yeah.
And I like what you brought up, because recently in Nature magazine, there was a very big editorial about how surgeon scientists are kind of on the downswing because surgeons have so many demands. Like I said, we're taping shows at night, and it's really easy to punch in and punch out. Surgery and medicine, there's more demands. It's a tougher and tougher job. And science is kind of going by the wayside for a lot of people. A lot of surgeon scientists don't feel like they can do it all, and it's
meaning it's hard to have a lab and be running gels and doing experiments as well as having a surgical practice.
Absolutely. So this is a shout out to surgeon scientists, wherever you are. Keep rocking. So let's get into bladder cancer.
Yeah.
So how does it present? Give us a primer. When does a urologist get involved?
It's interesting. Bladder cancer is it's like the hidden cancer that people don't talk about. As you said, it's very prevalent. It's present in both men and women. People die of bladder cancer, but people don't talk about it very much. It's a little bit of a hidden malignancy. The vast majority of patients, it presents with blood in the urine, hematuria. Anytime someone sees blood in the urine, they need to get checked out. And one thing that is really troubling to us, I think you've probably seen this, is someone's had blood in the urine and maybe they've had it in there for 9 months, 10 months, and they haven't been checked out, or maybe they've gone to a small clinic and be given antibiotics, and someone assumed they had an infection, but they didn't culture the urine. Someone had blood in the urine. It wasn't checked out. It's pretty simple, except for some specific situation with young women who have blood in the urine at the time of an infection. In general, if you have blood in the urine, you need to have it evaluated. And the way we evaluate it is by doing some x-rays, doing a CAT scan, what we call a hematuria CAT scan, sending the urine out for some specific tests, and then looking in the bladder with a little tiny flexible telescope, which is called a flexible cystoscopy. So the average man or woman with bladder cancer presents with painless blood in the urine without any particular voiding symptoms. Occasionally, certain kinds of bladder cancer will present with some burning with urination and frequency, what we call irritative voiding symptoms, or in more advanced cases, when the kidney is blocked on either side, someone could have flank pain from ureteral obstruction. But most patients, it's just Hawaiian punch, red wine, pink lemonade, just bloody urine.
And what's amazing about that, taking care of all these patients with you in our practice, is that it's amazing how many people sweep this under the rug.
Sure.
And I've heard I've heard of all kinds of crazy excuses. I heard somebody telling me, lifted something heavy. Oh, I drank too much beer. I had some cognac. I was mad. I've heard every reason why you could have blood in the urine. But basically, if you have blood in the urine, go see somebody and get it checked out.
But it doesn't always mean cancer.
Correct. Yeah,
you could have blood in the urine. You could be passing a stone. You could have blood in the urine. It could be an infection. It could be exercise-induced. There are plenty of benign things that cause blood in the urine. However, you don't want to miss bladder cancer. And as you said, there's kind of two families: the superficial disease, where it's just of the lining, and the invasive or deep type of bladder cancer, where we have to be a lot more aggressive. You want to get things early when it's just of the lining of the bladder and not going down into the muscle. So early detection, it's a good thing.
Got it. Now,
prevention's even better.
Oh yeah, we can talk about that actually before we get into the treatment, because bladder cancer is one of these epidemiologic, or if you study populations, it's actually pretty easy, because how do you get bladder cancer?
Well, the most common is smoking in this country. So smoking cigarettes causes certain chemicals to be filtered into the lungs, into the bloodstream, into the urine, and then the lining of the kidneys, the lining of the ureters, and the lining of the bladder are bathed in these carcinogens, which cause bladder cancer. And then there's a host of other chemicals that can cause this. Different kinds of dyes, aniline dyes, different kinds of solvents to clean equipment with, benzene, toluene, things like that. And then some specific types of medications that can increase the risk, and then some more eclectic things that are interesting to test medical students on, like schistosomiasis, infection, different parasitic infections.
Yeah, that's a good point, is that this is a worldwide disease, and the nice thing about what our series is, and I've been seeing hits from all over the world, which is like awesome, so I didn't really plug it much from the last episode, but subscribe, watch Concord TV, you know,
tell your friends about
tell
Dr.
your friends.
Yap.
It's a great series. Keep rocking. But I see hits from all over the world actually, and in Egypt especially, schistosomes, a parasitic infection, causes a very nasty form of bladder cancer, a squamous cell carcinoma.
Yes.
But in America, you're essentially talking about the lining of the bladder, transitional cells that are the lining of the bladder, and I think doesn't get as much billing as it should because everyone talks about smoking and lung cancer. Bladder cancer really isn't on the radar, but it should be because they're all nasty cancers, and it's one of the major risk factors for getting a bladder cancer, smoking. Now, let's say we have a patient with the superficial or the more common disease.
Sure.
You've diagnosed it on a blood in the urine evaluation. What do you tell the patient, and how do you proceed from there?
So let's say that we've looked in the bladder and we've seen something growing from the lining of the bladder. The next step would be to bring the patient to the operating room, have them undergo a general anesthetic or a spinal anesthetic, and then again, looking into the urethra with a small camera, we would then remove that area and biopsy what the lesion is and then what's underneath it. We want to get an idea histologically what the cells look like and then how deep it goes into the bladder wall. We kind of look at things in two ways with any malignancy. We look at the grade of the tumor, which is how abnormal the cells look. The lower grade tumors look more like the cells they originated from. The higher grade tumors look more primitive and evil. So high grade versus low grade, for example. And then we look at how deep things go into the bladder. Is it something where it's some flat cells just of the lining? That's what we call carcinoma in situ. Is it a polyp, kind of almost looking like a piece of broccoli, just of the lining, TA, a little bit down into the lining, but not down into the muscle, T1, or down into the muscle, which was what we would call T2. So depending on what the grade is under the microscope and how deep it goes, that kind of helps us figure out on the algorithm what the next treatment will be for the patient.
Yeah, and I like your point about the different architectures because usually we're talking about a polypy thing, but there are variants that look like just like an innocent red rash, and that's one of the more nasty kind, those carcinoma in situ type cancers. So you've done a resection and you have that pathology.
Yes.
What do you tell the patients based on the different pathologies? Because we know about the different, adjuvant therapies, et cetera, but for the general public who may not be as aware of the different, treatment options or how you follow them, what do you tell them based on, the lower grade versus the higher grade type diseases?
So we'll start with, again, like you said, most patients have superficial disease. Whether it be low grade or high grade, most patients are on the side where we're not talking about disease into the muscle, where we're considering chemotherapy, removal of the bladder, things like that. So on the superficial bladder cancer side, I think you have to roughly say low grade and high grade. So there are a lot of people with low grade, not very aggressive looking cancer, TA bladder cancer. So just of the lining, and this can be multifocal in a lot of different spots and prone to recurrence, but is at pretty low risk for developing into muscle invasive disease. And it's the disease into the muscle that can go to other parts of the body and cause someone's death. So someone with a low-grade superficial bladder tumor, we remove it, and then we would set up a surveillance to kind of keep a close eye on them. I'd say you may have a 30 to 50% chance that you form other polyps like these, almost like someone with colon polyps. You might form other lesions in the future. Let's stop any risk factors right now that you're doing that may make you predisposed to this. And then let's set up a regimen. We'll look in your bladder every 3 months for a period of time, then every 6 months, and then yearly. Sometimes we can cauterize small recurrent lesions in the office. If someone has a recurrent lesion, sometimes we'll have to go back to the operating room. But these are more an annoyance than a true risk to the length of someone's life. So then the next would be, let's talk about a TA tumor, again, just the lining, but high grade. These are ones that if left alone, high grade superficial tumors, they turn into the muscle invasive tumors. So a high-grade TA we would remove, and then we'd recommend putting medicine into the bladder once someone has healed, once a week for 6 weeks. And that medicine, which is called BCG, is an immunotherapy. It's not a chemotherapy. It stimulates the immune process within the bladder, and it gets the bladder's own T cells to fight cancer and to prevent future cancers. So it ramps up all of these cytokines, all these chemicals in the bladder that causes the immune function of the bladder to be more effective. And so a patient comes into the office once they've healed from their surgery, and then the nurse will put a small catheter in, squirt in this medication, which is actually an attenuated tuberculosis vaccine, BCG, take the catheter out, and then the patient moves around different positions, bathes the bladder, and then comes back 5 more times. And then they're continued to be watched. And then if they agree to it, not everyone agrees to it, there's a protocol where every 6 months for 36 months, the patient gets 3 reminder doses. We call that maintenance therapy, maintenance BCG therapy, as per this big research group called the Southwest Oncology Group, or SWOG. So the high-grade superficial patient gets resected, gets followed closely, gets induction BCG, 6 weeks of this treatment in the bladder, and then if they agree to it, maintenance therapy every 6 months for 3 doses and closely following them. And if people agree to this, we save bladders.
Oh, yeah.
We save lives and we save bladders. They're
key.
less likely to develop invasive disease and need their bladder removed, and they're less likely to die from bladder cancer. So it's amazing that someone stumbled across that intravesical therapy, intravesical in the bladder.
Yeah.
And it works.
This is the funniest thing about it is, like, you know, the guy that decided one day to take live bacteria and put it in a catheter inside somebody's bladder. I mean, sometimes the best
Probably
medicine...
someone like Dr. Yap.
Yeah, sometimes the best medicine borders on lunacy, actually, you know?
Well, tell them how Viagra was discovered.
Yeah, well, that's a good side segue, you know. The PDE5 inhibitors, or the erection medication, really were designed for people with angina or heart problems, and as a side effect...
All these guys wanted more of the test medication.
They didn't want to return the medication, actually, which is pretty amazing. And they said, hey, you know what? Not so good for that vessel, but maybe it'll work for another one. So BCG, it's actually huge. One thing, just to get, you know, using the power of the media and this worldwide reach, I don't want to get this show to my head too much, but I got to tell you, BCG critical, you mentioned and outlined how critical it is. There's a shortage sometimes of this medication.
There sure is.
And it's absolutely ridiculous, and our national organization, the AUA, has been involved in this, is that make this available for our patients. You know?
I think there are a limited number of places producing it, and we've had some shortages over the last couple of years.
Yeah, and it's like this and a few selected other medications where it's really bizarre how the business of medicine is consolidated to there's only one manufacturer or two, and for business reasons, they'll just pull out, and you know, and you're kind of left high and dry. But we got plenty for now. I haven't heard of any recent shortages, but it's definitely a very important medication.
Sure, and I'll just, for completeness' sake, for patients who have recurrences after having BCG, there are other formulations of medicines to put in the bladder. BCG mixed with alpha interferon, mitomycin, et cetera. So there are other things out there that for other salvage intravesical therapy.
Yeah, and that's a good point, where BCG is definitely very important for the higher grade disease, but other medications like mitomycin C, which is another type of chemotherapy, can be used to prevent recurrences. It won't prevent it from getting worse or progress, but BCG is the big one. Can you give me a few words about the slightly higher grade? We talked about the TA high grade, but there are some people that do need to get a re-resection, and I don't think a lot of people in the community or other patients know that when we have certain types of diseases, by definition, you should go back. Sometimes I talk to my patient, I say, well, unfortunately, you've got the T1 grade 3 type disease, we got to go back. Sure. And the patient will say, whoa, did you not get it all? That's a little bit of a different animal.
So for TA or carcinoma in situ, that flat one, once you diagnose it, you can move straight towards intravesical therapy and following someone. If someone has T1, which is down into the lamina propria, which is the base of the lining, but not quite into the muscle, if you take 100 patients who have T1 bladder cancer, and pretty much all the T1s are high grade, if you take 100 people with T1 bladder cancer, about 20% of them really have muscle invasive disease but you didn't really see that spot in the area that was looked at by the pathologist. So because of that, and because the stakes are so high if you miss muscle invasive disease, T2 disease, the recommendations nationally are, if you have a T1 tumor, the first thing you do is you go back and re-resect. That means you're going back to a crater where you've removed a tumor and you're removing tissue underneath it, making sure you have muscle in the specimen, making sure that there is not muscle invasive disease, because it's a whole different pathway. And if you get off track and start giving medicine into the bladder and watch someone may continue to progress because you didn't realize they had muscle invasive tumor.
Yeah, and that's the whole concept that is known as upstaging, where you get what you get. Now, I think also another nuance of the procedure is that we're talking about natural orifice surgery. It's one of the oldest forms of natural orifice surgery, where urology was really founded upon telescopes going into channels to take care of people.
Yeah, we're not cutting anyone open
no,
for
it's
all of the surgery. This is all through the urethra.
Through natural urine channels, but you have to have a gentle hand with the scope. And we talk about the concept of re-resection because the bladder lining, it's pretty pliable, but you can perforate the bladder, and we don't want to just go womping in there with like a lightsaber and take a big chunk out of somebody's bladder. You just want to get the tissue you need for bladder sparing. But there are some circumstances like that T1 grade 3 that you had mentioned where you need deep tissue, and it's always a balance.
And it's the patient with high-grade T1 that recurs with high-grade T1, or carcinoma in situ that keeps coming back after intravesical therapy time and time again. Those are the patients where we will do a bladder removal for superficial disease before they get to muscle invasive disease, because you've essentially exhausted your options and there are no other therapies, and you don't want them to progress.
Sure, and those are the bad actors, but that's why you try to hit them hard. Good resection, get them with the BCGs, get them on a maintenance pathway. And I think the key thing too is definitely compliance. And I think you mentioned that, is that this is a lifelong process, and the patients have to have a commitment to really coming in because, like you mentioned, there are a lot of cases where you can get these in the office.
I make it pretty simple for a patient with high-grade disease. If someone has a carcinoma in situ or a TA that's high-grade, I say, we're going to know each other for a long time. They're probably going to hear all my jokes. I say, I've got some simple goals. I don't want you to die of bladder cancer. That's goal number one. Goal number two, I want you to keep your bladder. Now that means I'm going to be looking in there a lot. I'm going to be recommending medicine and maintenance therapies. And if you want to have those goals be a priority, then we'll kind of go down that avenue. And people respond to that.
Absolutely. I think it focuses people because I think it's such a long litany, quarterly scopes, maybe more BCGs, and sometimes the patients will get kind of demoralized. Man, why do I keep coming in? Why do I keep getting surgery? And having you say, listen, don't die. We want you to keep your native bladder. That's enough incentive for me. Now, for the BCG, just to get back to that for a second, what types of side effects can people experience from that? Because it's pretty potent stuff.
Yeah, the most common thing would be, as that immune function is ramped up in the bladder, you have inflammation in the bladder. And when the bladder's inflamed, people get what we call irritative symptoms. So you have to urinate more frequently. There'll be some burning with urination. Those are the most common things. Occasionally some blood in the urine. Rarely, if someone absorbs the BCG, they could have a fever. That's a very rare occurrence. But that's why you have to be careful when the catheter is being put in for BCG. If there's any trauma or it's difficult to put a catheter in, you throw the flag and you don't put the medicine in that day. Thankfully, in the last decade, I haven't seen a febrile BCG patient. But in Boston, I remember seeing a couple of people admitted after therapy. So it is something that happens, so you always have to warn someone.
It's pretty rare. It's pretty rare, absolutely. And if it does happen, then you can get treated with actually tuberculosis-type drugs, because it's is a vaccine for tuberculosis. So if it's really severe, then medications can be used. But by and large, very uncommon. In fact, I can't even think of in our practice someone that's ever been hospitalized for something like this. It's been very rare in like the 10 years I've been involved. So, so I think this is a good place to wrap it up as far as part one. So we talked about superficial disease, diagnosis of bladder cancer, and introed Dr. Santis to the whole world of the television, electronic media, wherever. So subscribe and take a break. It's a terrible joke I keep saying, but take a bathroom break. Come back for part two. and we'll talk about muscle invasive disease and the surgeries that exist for addressing people with the more deeper form of the disease. So thanks for watching.